Welcome back to Scrubbed In, the DVM Journey, the podcast where we dive into the wild, rewarding, and sometimes unpredictable world of becoming a doctor of veterinary medicine. I'm your host, Grace Gaynor, a current fourth-year veterinary student at the Virginia, Maryland College of Veterinary Medicine. Whether you're an aspiring vet, a vet student, or just passionate about animals, this is your backstage pass into becoming a DVM. From classroom to clinic, we're sharing the insights, tips, and real-life experiences to help you thrive on your journey to becoming a vet. So scrub in, and let's get started. Welcome back to Scrubbed In. I'm your host, Grace Gaynor, and today I'm starting a new series called NAVLE Nuggets, where I hope to briefly review some important topics that I think will likely show up on the NAVLE. So whether you're a vet student reviewing for the NAVLE or a pre-vet student wanting to learn more about some cool vet topics, I hope this will be a helpful overview. Quick disclaimer before we get started, I'm currently a fourth-year veterinary student and not a licensed veterinarian yet. The information in this episode is based on resources including the Zuku NAVLE prep course, my veterinary school notes, and the Merck veterinary manual. While I've done my best to provide accurate information, mistakes can happen, so please use this episode as a supplemental learning resource and refer to primary resources and veterinary professionals for definitive guidance. Today we're covering 4 juvenile orthopedic diseases in dogs, including hypertrophic osteodystrophy, Panosteitis, Osteochondrosis Dissecans, or OCD, and avascular necrosis of the femoral head, also known as Legg-Calvé-Perthes Disease. These conditions can seem overwhelming at first because they all involve young growing dogs, but the key is learning the signalment and where the lesions occur, and that is going to help you nail these on the NAVLE. So let's dive in. Imagine you're seeing a 5-month-old Great Dane puppy. The owner reports that he suddenly became lame in multiple limbs and now doesn't want to stand. On physical exam, he's painful over his distal radius and ulna, so towards the wrist or carpus, and has a fever. What is your top differential? Hypertrophic osteodystrophy is correct. Let's break down that word, hypertrophic osteodystrophy. Hyper means excessive, and trophy means growth. So essentially, hypertrophic means excessive bone growth in this context. For osteodystrophy, osteo means bone, and dystrophy is a term for defective or abnormal. So osteodystrophy means abnormal bone development. The pathophysiology of HOD is that it is an inflammatory disease affecting the metaphysis of rapidly growing long bones. If you don't know what the metaphysis is, it's the wide transitional section of a long bone located between the diaphysis, which is basically the central shaft of the bone, and the epiphysis, which is the rounded end of the bone. For HOD, the cause is not definitively known, but it is possible that there is a heritable component. For HOD, the common signalment includes puppies that are 2 to 6 months old, specifically young, growing, large, and giant breed puppies. Weimaraners, German Shepherd dogs, and retrievers and Irish setters can be predisposed. HOD clinical signs, there can be a variety of different presentations. They can have variable pain and lameness, from mild lameness to inability to walk on presentation. Most notably, swollen metaphyseal regions of the long bone indicates HOD. Specifically, the radius, ulna, and tibia are the most common bones affected. With HOD, you can see other nonspecific signs including fever, lethargy, depression, diarrhea, and anorexia. So to summarize, these puppies often appear genuinely ill, and sometimes they're mildly lame, and sometimes they just can't walk at all. To diagnose HOD, we want to use the history, physical exam findings, and radiographs. When we take radiographs, we're going to be looking for a radiolucent line parallel to the growth plate where the metaphysis is. This creates a classic double physis sign. It's important to know that radiographic signs may lag behind clinical signs, so if you're concerned about a dog possibly having HOD but you don't see anything on the radiographs, have the patient come back a week or 2 later to repeat the radiographs and see if any changes have developed. The treatment for HOD includes analgesics for pain control and supportive care for systemic illness. If they're systemically ill, you might want to provide IV fluids, nutritional support, and antibiotics if indicated. The good news is, generally the prognosis for HOD is quite good. Most animals respond to supportive care, and the disease is generally self-limiting. Unfortunately, if they have severe systemic signs, the prognosis is guarded to poor. An important key note to tell owners when you diagnose HOD is that recurrence can occur, and it typically doesn't resolve completely until a dog reaches skeletal maturity. Most notably, an angular limb deformity may develop due to repeated metaphyseal inflammation. So now that we've gone over the important parts of hypertrophic osteodystrophy, here's a quick memory trick to help you guys lock down these concepts. HOD stands for hot, ouchy, and down, representing that the dogs can present with a fever, they feel really ill, they'll be ouchy on their legs, maybe have some lameness, or they will be completely down. For me, I also remember this because hypertrophic osteodystrophy is a longer word than some of the other diseases that we're going to talk about, and so the longer word has more systemically ill presenting disease. Let's talk about our next case. Let's say we have a 10-month-old German Shepherd presenting for intermittent shifting leg lameness. The dog is otherwise healthy. What is your top differential? The correct answer is panosteitis. This can be remembered as growing pains. Panosteitis is the number one juvenile bone disease in dogs. Panosteitis is an inflammatory disease of the bone marrow of long bones, and the etiology is not completely known. They think that maybe diet and genetics may play a role in the development of panosteitis. The common signalment that we see includes puppies in the age range of 5 to 18 months old. Similar to HOD, panosteitis does affect large breeds, more males than females, and as I mentioned in the example, German Shepherds are a classic dog that will develop panosteitis. Clinical signs that you can see with panosteitis includes an acute onset without any known trauma. Shifting leg lameness, this is a big one that is typically attributed to panosteitis. On your physical exam, you may palpate some pain on long bones. The patients can be febrile, and forelimbs are more commonly affected than hind limbs. To officially diagnose panosteitis, we want to combine our history, physical exam findings, and radiographs. On radiographs, you're going to want to look for increased medullary opacity, and you may see these distinct thumbprints or mottled appearance in the long bone. The lesions are typically multifocal to coalescing regions of mineral opacity within the medullary canal, centered around a nutrient foramen. This, similar to HOD, can have normal radiographs on initial presentation. So if there is a high clinical suspicion for panosteitis, you want to recommend that the owners return in 1 to 2 weeks to repeat radiographs to see if there are any changes. The treatment of panosteitis includes analgesics, exercise restriction, and time. This too, like HOD, will typically spontaneously resolve, especially in young patients when they reach skeletal maturity. So overall, the prognosis is quite good. This is a self-limiting disease. The treatment is supportive, and generally it resolves as the animal reaches skeletal maturity. One exception to this is German Shepherds. They may flare up after skeletal maturity up to 5 years old. A quick memory trick to remember panosteitis, in addition to remembering that it is the disease that causes growing pains, is to remember that panosteitis represents pain in the center. The lesion is in the medulla, in the middle of the long bones. Let's move on to our next disease. Now imagine a 7-month-old Labrador Retriever presents with chronic forelimb lameness. Radiographs show a subchondral bone defect in the shoulder. What is your diagnosis? Hopefully you came up with Osteochondrosis Dissecans, or OCD. Now, Osteochondrosis Dissecans is an orthopedic disease that is defined by a failure of endochondral ossification. In normal ossification at the epiphysis, or the end of the bone, the outer layer becomes normal articular cartilage, whereas the inner layer, which begins as cartilage at a young age, is eventually converted to bone. In OCD, ossification fails, which results in an abnormally thickened outer layer of cartilage on the end of the bone. This cartilage thickening is actually called osteochondrosis, and it is asymptomatic. As a young dog is active and normal forces are applied to this abnormal cartilage, it causes trauma to the cartilage and results in flap formation, which is called Osteochondritis Dissecans, or OCD. OCD is symptomatic. Hopefully you're catching the nuance here, but let's go over it again. There is a key distinction between osteochondrosis and osteochondritis dissecans. Osteochondrosis is thickening of cartilage that is asymptomatic and due to failure of endochondral ossification. Osteochondritis dissecans is the clinical form of this disease where a articular flap is formed. In OCD, when a cartilage flap forms, subchondral bone or the bone underlying the cartilage is exposed, which results in joint inflammation and ultimately leads to degenerative joint disease later in life, even with the ideal treatment, which we're going to discuss shortly. The common signalment we see with OCD is puppies approximately 4 to 8 months old. Similar to HOD and Panosteitis, it's in young, rapidly growing large breed dogs. Nutrient excess can be a risk factor, so possibly puppies that are being overfed. The common locations of OCD include most commonly the shoulder, specifically the caudal humeral head, and this has the best prognosis. There are other locations that we will see OCD, but these are less common, and I'm going to tell you them in order of worsening prognosis. The next location that we see is the elbow, specifically the medial humeral condyle, the stifle, the lateral femoral condyle, more commonly than the medial, the tarsus, the medial trochlear ridge of the talus, more commonly than the lateral trochlear ridge of the talus. The way I remember this is that I literally take my hand and I touch the outside of my knee and the inside of my ankle, and that helps remind me that in the knee or in the stifle, the lateral femoral condyle is more commonly seen with OCD than the medial femoral condyle. And in the tarsus, or the ankle, the medial trochlear ridge of the talus is more common than the lateral trochlear ridge of the talus. Clinical signs that we can see with OCD include gradual onset of lameness, which can be either unilateral or bilateral. We may also see joint effusion, and on our physical exam, we may see pain with manipulation. To diagnose OCD, radiographs are number one. There are a couple things we want to look for, including a flattening or concavity of normal bone contour, subchondral bone lucency, in which the bone is less opaque than normal, or, on the other end of the spectrum, sclerosis, which is an increase in bone density, showing a more opaque bone on radiographs. Sometimes we can also see a radio-opaque flap, as once the cartilage flap detaches over time, it will actually ossify as a result of synovial nourishment. Now, I had to look this up because I literally did not know what that meant, but basically, when the OCD flap detaches, it loses its primary blood supply, but if it remains in the joint capsule, which often it does, it attempts to survive and ossify through a process known as synovial nourishment, and this nourishment refers to how a vascular cartilage receives essential nutrients from in the synovium, and that allows it to continue developing into bone. And that is how we're able to see it so clearly on radiographs. One important thing to note is that we always want to radiograph the contralateral limb. Contralateral OCD is common, so if you see it in one joint, it's most likely in the same joint on the other side of the body. Other things we can use to diagnose OCD includes contrast arthrogram, ultrasound, CT, and MRI. So how do we treat OCD? Surgery is the gold standard. We want to remove the flap, and we can do that via open surgery or arthroscopically. The goal is to debride the loose cartilage and remove that flap. We also want to make sure to debride to the bleeding subchondral bone, because once we get down to that subchondral bone, that's going to help stimulate fibrocartilage formation, which is going to help stabilize the bone. Another thing that we can do to treat OCD is conservative management, although this is not typically very successful. This includes NSAIDs, exercise restriction, calorie restriction, and weight control. So this can be used short-term, but surgery is preferred. There are some other cutting-edge treatments, such as osteochondral grafts or synthetic cartilage, but I'm not going to take the time to discuss those now, as those are not well documented at this time. So again, to review, prognosis of OCD lesions based on location. The shoulder This has the best prognosis. The elbow, guarded to fair, the stifle, guarded to fair, and tarsus, guarded. Either way, no matter which joint OCD occurs in, this dog will develop arthritis, no matter what we do. Our goal is to intervene early with surgery and hopefully minimize the damage, but ultimately, every dog that gets this issue will develop arthritis. A quick memory trick to remember OCD is that OCD equals a cartilage problem in the joint. Let's move on to our last disease. A 7-month-old Yorkshire Terrier presents for progressive hind limb lameness. On orthopedic exam, hip extension is painful and there is noticeable muscle atrophy of the affected limb. What is your top differential? The answer is avascular necrosis of the femoral head or Legg-Calvé-Perthes Disease. For reasons that are not completely understood, in this disease, blood supply to the femoral head becomes disrupted, and without adequate blood flow, the bone dies, the femoral head collapses, and secondary osteoarthritis develops. The common signalment we see with this disease includes toy breeds and small breed dogs, typically 4 to 12 months old. The classic breeds that we see include Yorkshire Terriers, West Highland White Terriers, Mini Poodles, and Pomeranians. Clinical signs that can be seen with avascular necrosis of the femoral head include progressive hind limb lameness, hip pain, which can be unilateral or bilateral, decreased range of motion, and muscle atrophy. To diagnose this condition, we want to use our history, PE findings, and radiographs. On radiographs, we're going to look for an irregular femoral head. We can also see increased radiolucency, and often we're going to catch these cases when there is true collapse of the femoral head and neck. To diagnose this, we want not only a straight VD of the hind legs so that we can see the hips, but we also want a frog leg view, which allows us to better view the femoral head and neck, and that will help us diagnose this disease. The gold standard treatment for avascular necrosis of the femoral head is femoral head and neck ostectomy, or FHO. FHO is a surgical procedure in dogs that actually removes the femoral head and neck, or the ball of the ball and socket joint, and by eliminating that bone-on-bone contact, you essentially eliminate the joint. It's kind of a crazy procedure, but I've seen it done in many cats, and it's actually wildly successful. The surgery relieves severe hip pain and allows the surrounding muscles and scar tissue to develop and create what's called a functional false joint. In some specialty centers, they may want to pursue a total hip replacement in select cases. So a quick memory trick to remember avascular necrosis of the femoral head or Legg-Calvé-Perthes disease is that Perthes equals poor perfusion, and the blood supply is lost to the femoral head and the bone collapses. Let's do a quick pop quiz. Which disease is caused by abnormal cartilage development and commonly affects the shoulder? The answer is OCD. A 6-month-old Yorkie presents for unilateral hind limb lameness and hip pain. Radiographs show collapse of the femoral head. What is your diagnosis? The answer is Legg-Calvé-Perthes disease. Question number 3. Which disease commonly causes shifting leg lameness in a young German Shepherd? The answer is Panosteitis. And finally, which developmental orthopedic disease causes fever and a double physis sign? The answer is HOD, or Hypertrophic Osteodystrophy. So to summarize, think about the location when you're assessing these questions on the NAVLE. HOD occurs in the metaphysis. Panosteitis occurs in the medulla of long bones. OCD occurs in the articular cartilage of joints, and Legg-Calvé-Perthes, or avascular necrosis of the femoral head, occurs in the femoral head. If you know where the lesion is and understand the common signalment, you'll usually get the diagnosis right. I hope that quick review on juvenile canine orthopedic diseases was helpful. If you have any feedback, feel free to comment below. This is obviously the first time I've done this, so let me know what you think. Thank you guys for tuning in, and I hope you'll listen to the next NAVLE Nuggets episode, out each week until I take the NAVLE in October. Until next time, my name is Grace Gaynor, and I am scrubbing out. That's a wrap for today's episode of Scrubbed In, the DVM Journey. Thanks for tuning in and being a part of our community of future vets and animal lovers. If you enjoyed today's episode, don't forget to subscribe, rate, and review. It helps others find the show and join the conversation. And if you have any questions or topics you'd love to hear about, feel free to leave us a comment. I'd love to hear from you. Until next time, keep scrubbing in, and remember, the journey to becoming a DVM is one step at a time.